I'm basically just going to go over a little bit of the anatomy, a few things that tend to pop up with patients and problems, and just give a brief overview of what we are trying to achieve here. The people that are late can come in.
So you're on the video now.
Oh, sorry.
Do you want to sit in front?
There's one right in the front and
Yes,
there's two right at the back. Okay, so we're going to start a bit with anatomy. So Pam's going to be my remote. All right. So the shoulder girdle is actually a very, very complicated joint because it isn't just what most people think about, the ball and socket joint of where between the arm and where the shoulder blade meet. Because how is it actually attached to the body? Most people think, oh, it's a ball and socket joint, but actually what is the socket is actually your wing, as Melanie will talk about wings just now, but that's your scapula. And how is that actually attached onto the body? Purely with muscles. And most people don't think about how is your arm actually attached to your body. So from the wing, it is onto the rib cage with muscular attachments. Then on the front, we have on there, can you see the writing at the back there? Okay, so sternoclavicular, so your collarbone in the front here attaches onto your sternum with a tiny little joint there. That is actually the only way, bony attachment, it is attached to the rest of the body. And we never think of that. Tiny little joint is how the whole arm is attached in the front here. Never mind on the side, on the front there. Then going further to the side is what we call the acromioclavicular joint. So it's between your collarbone and then your scapula. Okay. And again, it's a tiny little joint, if you can see it over here. Tiny little joint over there, where it's joined there. And then again, the scapula is the ball and socket joint. So just briefly going through, so your humerus is your arm, the scapula is your wing, and then your clavicle is your collarbone. And that's the most commonly broken bone, is your clavicle. And you can think of even from kids falling off little bicycles and stuff, that's what you usually break, is the collarbone. Okay. Looking at overview here, what I really wanted to show is, now you've got a stiff shoulder. Can you see?
Okay.
Okay, good. You've got a stiff shoulder, but actually why do you have a stiff shoulder? Now this shows the whole body, and I'll just briefly go over how it's connected. From your neck onto your shoulder, it's your upper trapezius. Now, if you've got a stiff neck, it affects your shoulder, or does the stiff shoulder affect your stiff neck? Chicken and egg, we don't know. And then here, I've shown all these muscles where your shoulder girdle is attached onto the spine. So is it your stiff spine that's giving you a stiff shoulder, or is it the stiff shoulder that's giving you a stiff spine? Who knows? Come in. Oh, to the back. Naughty child, to the back of the class. Naughty. And for those that don't know, that's my mother. Then coming down the bottom here is your lats. And you can see your lats is actually attached to your thoracolumbar fascia. So again, is your stiff back giving you your stiff shoulder, or is your stiff shoulder giving you your stiff back? How interesting is that? So we're talking about the shoulder, but I've got a chart of literally the whole body. Coming down here, this is serratus posterior, inferior. That's attached to your ribs, and Melanie and Barbara are going to go more into your breathing and how that can be affecting your shoulder as well. So as physios, we often, and Tammy the bio is also going to go into looking at your whole posture. Why do we do that? Is because everything's actually all connected. So we can't actually, you come into my practice and say, I've got a sore shoulder. I'm going to look at your whole posture and say, why do you have a sore shoulder? Because everything is connected. And then going a little bit closer, as you can see the muscles of the arm as well. I always include biceps and triceps. And my first step of training and strengthening is usually bringing in biceps and triceps as well. So no, might not think of it as the shoulder. Oh, well, we're moving the elbow. But the influence on the shoulder is quite large as well. And then I brought in, for me, as a physio, I find that weakness of serratus anterior And yes, there's a test afterwards. Hold the shoulder blade onto the thoracic spine. And if we've got weaknesses there is where we start getting the wings. But I find that's such an important area to rehab, whether it's a painful shoulder or a stiff shoulder or weakness. That serratus anterior is quite important. On to the next one, rotator cuff. I think one of the most important areas that I see is obviously from, I'll go into detail on pathologies, but I just wanted to give you a nice overview of that before we go on to that. So it's made up of 4 muscles. Supraspinatus is the one in the fossa here, and it's the most common rotator cuff that's injured because it runs there under your acromion, and then it often gets squished in there as well. So that's your supraspinatus, and most of the tears can be in supraspinatus, but all 4 of them, infraspinatus is on the back here. Over the back of the posterior capsule there is an area which it develops a lot of stiffness. Your teres is the one that I have in green there, and then subscap is the one underneath again, from the underneath surface, so between the ribs and the scapula is where subscap comes, and those 4 muscles form the rotator cuff. What I wanted to show here, so if you took the ball part out, there's the socket, and you can see how everything comes together around that glenoid, which is the socket part, and that is the labrum, which is around the socket. And you can see the ball is very big in relation to the socket, and the labrum just helps stabilize the ball into that socket. Okay, moving on to the next one. Okay, I didn't want to go into too much detail, but when I started looking at things, I actually thought, well, I actually had to include this part as well. So sorry about the detail, but it's quite important to know a little bit more about the anatomy to understand what's happening when you get injuries. So on this side, that's what I showed you on the previous slide, that's the labrum. And your long head of biceps actually attaches to the top there. And that's why your biceps is so important for the stability of the shoulder. So actually the long head comes in and attaches there. This one looks very complicated. Loads of ligaments around. And then what I wanted to show you here is the bursa. And for me, as a physio, the most important is this subacromial bursa. And I find a lot of people get inflammation there. So if that bursa is inflamed, it's sitting underneath here. So when you move your arm, it's getting squished in there. So can you imagine if there's inflammation, and then every time you move your arm, it's getting further squished. And that's why we often see that these shoulders take such a long time to settle down, because that bursa in there keeps on being irritated and it's inflamed. Okay, so out of all of these, that's the most important bursa to be aware of.
So
And then,
can you just explain to us what a bursa is?
Okay, a fluid-filled sac. Does that make sense? So it's basically an area that decreases friction when the tendon runs over that area. Thank you for asking that question.
Sorry, so when they talk about bursitis, is that to do with
Inflammation of that bursa. So that little fluid-filled sac, which is allowing the tendon to run over it there, the supraspinatus tendon. So it comes from the fossa here, and then the bursa just allows for better movement. But if that bursa is inflamed, it can't move nicely over that area. Okay? And then onto the capsule. So your capsule is actually what your rotator cuff, there's those 4 tendons that I was talking about that make the rotator cuff. It actually attaches into the capsule. Go back a few slides for me. No, that's, oh, there. Where most textbooks show rotator cuff like this, where it's coming, it doesn't actually do that. Go back to the, it actually attaches into, forms part of the capsule, which then attaches around the joint. So when you have, say, your supraspinatus that is torn, it actually affects all of the rotator cuff muscles. And it's because of that capsule. And like there, it looks very complicated. It is complicated. And it's all around that ball and socket joint. So that's what makes the shoulder so complicated. To the next one. Okay, so I didn't want to again go into too much detail, but I wanted to give you a little bit of an overview of the movement of the shoulder and the scapula, excuse me. Because we have all this movement, and which is really nice because we can get our arm in all sorts of positions, but because of that movement we lack stability, and that's why the strength is so important. But just to give you an indication of the scapula and the humerus move together, but just to complicate things, they don't move in the same ratio, 1-to-1. The arm actually starts to move a little bit before that scapula follows. But what they generally do is say it moves in a 1-to-2 ratio. So the scapula is moving, yes, that is 1-to-2, yes. I had to think for a moment. Scapula is moving 60 degrees, the humerus moving 120 degrees to give you 180. But that's very broad. You look it up and you'll get different ranges, different textbooks are reporting different things. And then we even say that the last bit of shoulder movement actually comes from your thoracic spine, from your ribs as well. So, like I say, it's very, very complicated, but we call that the scapular-humeral rhythm of the movement in there. I've mentioned the scapular and humeral clavicular movement. So this guy here that attaches onto the sternum, the clavicle also has to move. So as you move your arm out to the side, you can see it comes up into elevation. So it's still attached onto your sternum. This end is coming higher. But there's actually an element of rotation as well. So if it doesn't get that last little bit of rotation, you don't have full shoulder movement. So quite often in a patient where we can't figure out why can't we get it up there, we actually just get that last bit of clavicular movement, and then you get the shoulder into that full movement. And as I've mentioned, the rib cage also moves. And this scapula, what I've got in the picture down the side here, it doesn't just move out to the side. There's actually all sorts of movements of that scapula as well. It can move outwards, it can move upwards, it can move downwards, it can move inwards, and it can also tilt inwards and outwards, just to complicate things further. But if we don't have that movement, you can see on this end here, that little, where we were talking about the bursa underneath here, and where your supraspinatus comes through here. If that scapula doesn't lift up there, you're going to again get pinching going on there. So you might have a little bit of stiffness in the muscles down here. This can't move out, and then we form a pinching on the shoulder there. So you can see why it makes our lives quite difficult. There's no simple thing about a shoulder. Okay, just going briefly into a few of the pathologies that we see, and I'm sure you've heard of these ones. Frozen shoulder or adhesive capsulitis, rotator cuff tears, one that we've kind of lumped all together, calling it subacromial pain syndrome, which is all of the stuff underneath the acromion. I'll go into details there. Osteoarthritis, and then labral tears. So the first one, the frozen shoulder. So there's that capsule I was talking about. So the frozen shoulder or adhesive capsulitis is that capsule which literally becomes inflamed and stiff. Okay, so frozen, literally it can't move. It can take between a year and 3.5 years to resolve, which that is a long time, very, very long time. It's divided up into 3 phases: the freezing phase, the frozen phase, and the thawing phase. Okay, so it sounds rather funny. The freezing, if it takes longer, that freezing phase where it slowly gets stiffer and stiffer and stiffer until it's locked in that position, and the thawing phase are roughly the same. So if the freezing phase takes 3 months, the thawing phase will take 3 months and then stay frozen in between. The literature has all sorts of different figures for this. So where physio comes into this, because it will still go through those 3 phases, and initially they used to say, well, just leave it because it's going to go through those 3 phases. But where we come in is in that freezing phase is where it's actually very, very painful. So we can help out with a lot of pain relief. We can, the research has actually shown that we can help shorten the freezing phase. So exactly what I've said, if we can shorten the freezing phase, we will shorten the thawing phase. then the overall picture will be a lot shorter. So isn't that what you want? Definitely. And some of the doctors then say, oh, we'll put you under anesthetic and manipulate it, but then you're going to end up with rotator cuff tears and all the rest. I'd rather nobody go under anesthetic and then just move your shoulder through range. It hasn't proven to help. So rather visit the physio and we'll help you through that. Okay. I want you to talk about predisposing factors because it's something that came up on adhesive capsulitis, but it actually is something that's pertinent to all the joints. Because it's an inflammatory problem, diabetes is one of the main predisposing factors, which when you think about it, it makes sense. If your sugar levels are higher, your inflammation in your body is higher. We need to, all of us, whether we're diabetic or not, we need to get our sugar levels down. Because if we can get our sugar levels down, we can decrease our inflammation, we can actually improve all of our joints. And we all tend to forget about that, me included. I've got a terrible sweet tooth. But if we cut our sugar down, we're going to actually eliminate a lot of these problems. The other factors which are unavoidable, they've said cardiac surgery. So if you have had bypass surgeries and things like that, it is a predisposing factor to a frozen shoulder, as well as breast surgery. So malignancy and those kind of things. It's a predisposing factor to the frozen shoulder. And then shoulder surgery. So say you've now had fallen, you've had rotator cuff tear, you've had it repaired, the surgeon puts you in a sling for 6 weeks and says no physio for some reason. You're stuck in that sling for 6 weeks and you don't move, they reckon that you've got a high incidence of frozen shoulder afterwards. So that's why just literally doing your pendular exercises, no movement, active movement, literally just using pendulum exercises improves your circulation, decreases the chance of a frozen shoulder down the line. So yes, when you see the physio and they get you doing very odd, silly pendulum, like, how's this helping? Think of the frozen shoulder. We want to prevent that. We want to improve the circulation and get the healing process going. There we go. Rotator cuff tears. I would probably say one of the most common things I see in my practice. And we get obviously full thickness and partial tears. Most of your partial tears we can treat conservatively. I would even be able to tell you if you have a partial tear or not from your symptoms before having your ultrasound. And I would say most surgeons don't operate on a partial tear anyway. It's the full thickness tear where you literally cannot lift your arm and you're going to need surgical intervention to repair that full thickness tear. But partial tears, I would advise that you don't have it seen to surgically. We can treat it conservatively. Yes, it takes time. But as you've seen, why it takes time? The whole shoulder joint is very, very complicated. So we're going to be treating your neck. We're going to be treating your thoracic spine. We're going to be treating stuff down here, and you're going, but I've come for a shoulder problem. But you can see why everything's all interlinked, and how we're going to help you just eliminate the pain and get you going. We're not necessarily going to be working directly on that spot where you have the tear. We're going to be working around it to improve the circulation so that we can get the healing going. Okay. I mentioned the subacromial pain syndrome. That sounds very complicated, and I've given a whole lot of problems in there, but I've actually covered already. We spoke about impingement, that poor little tendon underneath there that's getting squished in there. But again, why is that being squished? Usually through a whole lot of different reasons. Do you have instability in there that's riding up the shoulder and pinching underneath that acromion? The bursa we've actually spoken about when that gets inflamed and now you're further pinching underneath there. Calcific tendinopathy. It took me a while before I could actually get my tongue around that. So I'm sure some of you have heard of that before. You get calcium deposits in the tendon. Some people develop it, some people don't. Some surgeons like to operate on it. Whether you have it operated on or not, the body will reabsorb that calcium as long as you are strengthening and as long as you're moving that tendon through the full range, it will heal. You don't necessarily need surgery. And we want to avoid surgery at all costs. It causes scar tissue formation, all sorts of secondary problems, so let's try and avoid that. And a lot of people have calcium deposits in their tendons anyway. They function normally, so don't rush off and have that seen to. Go to the physio and they'll help you get you on track. Biomechanics of the shoulder, so if everything's moving incorrectly, then you'll be causing the pinching, you'll be seeing the physio for the pain, and then you'll go to Tammy for the strengthening. And that's why it's so important to go through the whole procedure to get the full function of the shoulder. We've spoken about the anatomy, but I want to reiterate that when you get, I'm going to go into arthritis in a moment, but when you get lipping of the acromion, you are decreasing that subacromial space and then more chance of impinging there. From a physio and from strengthening point of view, we're not going to change your anatomy, but we might change the way you do things so that you don't further pinch in that area. Okay. Instability I spoke about just now, where it rides up. Okay. Osteoarthritis, it's actually not such a big thing for people, is OA of the shoulder. 15 to 20% of people get arthritis in the shoulder, and mostly women over men. So it's not a common joint that I see replaced and needing physio afterwards. So 15 to 20% is not very high. And most people get by because we're not walking on our hands, and we don't all need to get up here. Most people function in this range of motion. We can't change the anatomy. If you have arthritis, we can just help with increasing the circulation and help increasing the range of motion. And we're not going to change the arthritis in the joint. I wanted to mention this. I was going to leave it out because it's a bit complicated, but I just simply, that labrum that I was talking about increases the surface area of the socket part of the joint. Slap lesions is that long head of biceps that I said comes and it joins onto the labrum. That can get tears, most commonly when somebody falls on an outstretched arm. Some of them can be treated conservatively, but some of them not. It depends on the severity of the tear of that. And then a Bankart lesion is when the bottom part of that labrum is torn, usually from dislocations, and especially what they call anterior dislocations, so when the shoulder pops forwards, and especially if there's numerous dislocations on the shoulder. So some of those have to be repaired surgically, and then we rehab them afterwards. Okay. What do I do as a physio? That's the big question. All right. We help with the pain relief. Most people have pain associated with the shoulders. We mobilize the joints, soft tissue relief, spasms, stretching, those kind of things. We use dry needling, or we strap the shoulders. I use, if there's an unstable shoulder or even a painful shoulder, I use kinesio. I find that works really nicely. And then of course, strengthening is part of it. But we can't strengthen if there's pain. So we have to manage the pain first before we start strengthening. I usually start with very, very basic, usually with a TheraBand, all those pendula, pulley. We call the wand exercises. We use the stick. A lot of you know those exercises. Before then we start with more heavy strengthening, and then I'll be sending you on to Tammy for those kind of strengthening exercises. I was looking for some little sayings and stuff. I asked not for a lighter burden, but for broader shoulders. I thought that sounded quite nice. We will ask questions afterwards, but is there anything specific that you want to just quickly ask me about the anatomy and the movement of the shoulder? Okay, we'll leave it till afterwards. Then I'm going to hand over to Tammy, and then she'll introduce herself. Just give me a moment to set up her slideshow. So we're going to do a tag team quickly.
Thanks, Doug.
Sorry, Mel, I went over time.
Wow.
She looks so sorry.
Please address your complaints to Diane's website.
What's yours now? There. Oh, wait. Sorry, we've got two. Exit. Not that one. Not that one. It's on. Okay, got it. Wait, we need to get it back at number one. Okay.
Alright, so thanks for coming out, everybody. So my name is Tammy and I'm a biokineticist, and I'm just going to take you through the role of biokinetics with shoulder rehabilitation.
As I stand on the stage.
Sorry. Can everybody see that side as well? Okay, alright, so go on and next slide. Alright, so this is just an overview. I'm just going to introduce myself, give you a bit of information on shoulder health, our goals and objectives through your rehabilitation process, and then what we actually take you through. Okay. Alright, and then click again. Alright, so just a little bit about me. I've done my BA in sports science, and then I went on to move into my honours in biokinetics. And then I've just got a special interest in the orthopedics, neurological conditions, autoimmune conditions, and chronic conditions. So Parkinson's, lupus, osteoarthritis, those kinds of things. And then most importantly, what is a biokineticist? So we are exercise specialists from a healthcare point of view. So we basically use exercise and physical activity to help improve a person's physical well-being and overall health. And then the next one. Alright, so what is the importance of shoulder health? So shoulder health encompasses adequate strength and mobility. So we really look at strengthening the big muscle groups as well as the smaller ones that you don't really know exist. That's when you come to me and I put you through certain movements to really get into the deep ones that we don't generally access with everyday movements. Posture is important, and then our movement pattern. So how are you moving? What are you carrying a bag on one shoulder? How are you sitting at your desk? All of those are important aspects that we look at. So our shoulder is it's a highly complex joint, so it allows for a wide range of motion, and it actually sits in such a shallow socket over here that it really can move around a lot, so it's prone to injuries. Next one. So it's really crucial in many movements. We have to reach for things, we have to pick up glasses, we have to drive, so we really have to use our shoulder on a daily basis, and that's why it's so important for us to be able to strengthen and have the movement so we can perform those activities efficiently and without pain. So health of the shoulder is important. So our first goal and objective is injury prevention. So we use tailored exercise programs specific to what your body needs. So it's not a generalized program. I literally look at you from head to toe and I see, what do you need? What muscles do you need activated? What parts of the body? And that's where we move into. And we don't just want to help you with your current condition. We actually want to prevent you from re-injuring yourself for the same part that needs help and other parts of the body too. Then our other goal is postural support. So we look at the shoulder muscles that stabilize the shoulder girdle, and those are what helps maintain alignment. So we need to strengthen specific shoulder muscles that you need help with in order to provide that support and give you that actual posture. And then if we have healthy shoulders, we will have a decrease in the pain and dysfunction in other parts of the body. So Di mentioned that it's not just your shoulder, it's your neck, it's your middle back, it's your lower back, and generally some of those parts of the body are compensating for the fact that you have pain because you can't move properly. And then one of the most important goals, and that's a real big gauge for are you ready to leave me or not, is if you can return to your activities of daily living. Functional independence is crucial. You're going to need to lift things, you're going to need to reach things, you're going to need to carry your groceries. So we need to ensure that you're able to perform those activities adequately. And again, not re-injure yourself so that it hinders your ability to do so. And then our last goal and objective is a holistic approach. So, as Di mentioned, the body is a kinetic chain. One part affects the other. And we need to look at the interdependence of those systems. So how is your back affecting the middle back? How is your neck affecting the shoulder? And then what we do is, as soon as I've stabilized the area that you need help with and I've strengthened it, I start bringing that in with other movement patterns. A lot of the time I'll see when people walk in, they haven't got adequate movement in their middle back. They're not able to move their neck properly, and therefore their walking is hindered. So towards the end, before you move on to Pilates and have your maintenance side of things, I will bring what I've taught you in with other body systems and integrate it as a full movement pattern. And then your biokinetics journey. So the first thing that you go through is a functional assessment, where I evaluate your posture and biomechanics. So I look at how you're standing, I put you through certain movements just to see what the body is doing, and from there we can identify possible compensations. So if you're not able to move adequately, there's probably something else that's trying to do the movement for you. A lot of the time, if somebody lifts their arms overhead, we want to move as far as we can, right? But then we start maybe arching into the lower back and using other muscles to help us perform that movement. And then another thing is, through your history of when I chat to you, I can identify other contributing issues to what may be causing you pain. So for example, how long are you sitting at your desk? What is your occupation? Are you carrying a handbag on the one side that's allowing you to do this for most of the day? So all of those aspects can be contributing factors, as well as previous injuries. If you've had a whiplash or a car accident, all of those kinds of things can predispose you to developing other problems. Then the tailored exercises. So I've noted rotator cuff there just as an example. It's much broader than that, but again, like Di mentioned, that is one of the most important areas that we do generally focus on. Important is that we progressively increase the strength. So we need to rather go gently and slowly increase the intensity, otherwise you might land up injuring yourself. But in order to gain strength, we do need to increase your load. So that could be the intensity of the exercise, how many reps and sets you're doing, what weight are you doing, for example. So those are all examples. Then the next aspect is making sure that the exercises provide stability, which are those small muscles as well, and mobility for your shoulder blade, your neck, and your middle back. So this is specific to the shoulder. It can vary according to individual needs, but those are the main ones there. And then the last part is functional training. So we try and incorporate movements that mimic your activities of daily living, while you maintain the adequate posture and activation of the muscles that I teach you to use. Sometimes we compensate with other parts of the body, and I try and get you to use the body as adequately as possible without compensating while doing the activities of daily living. And the last part is proprioception. So proprioception is the body's ability to sense movement, action, and location. So we've got those nerve sensory systems within the muscles of the body, and if you've been injured or you have pain, you're not going to move as adequately. You've guarded that area, and you're not going to have that same sense as what your uninjured side is like. So with proprioception, that will help us improve your coordination. I see the C is missing there, sorry, and your control. All right. Oh, at the end there, sorry. All right, and then the last aspect is education, which is very important. So we guide you on the correct posture, okay? So where is your body positioned when you are performing these exercises and these movements? The next aspect of guidance is our ergonomics. For example, your desk setup. Sleep health is also quite important, like your pillow and your bed. Generally, Diane then will go into that before they send you to me, but if someone hasn't gone to see a physio, that's another aspect that I educate on because it's super important. And the exercise technique. So the homework exercises that I give you to do, it's so important that you know what to feel and how to do it so that you don't land up injuring yourself or causing injuries in other parts of the body. And then the last one is the importance of adhering to the exercise program. So Yes. This is the hardest part. This is a patience game. We are trying to undo years and months of bad movement patterns and pain. And when you've been in pain for a long period of time, your body needs to trust you again when I put you into movements that you possibly haven't performed before or you've avoided. And that's why I mentioned earlier, progressively increasing the strength is important. But it's not a quick fix. So that's something that I'll say to people when you come in, all I need from you is patience and trust, and if you stick to the exercises and you do the movements, you will get better. It just takes time. And the hard part about this is that I can't fix you myself. I can give you the tools to help you, but it comes down to the individual's actual dedication to doing it, and that is ultimately what will ensure that you get better and have improvements. And then I have just put some examples here. I'm not going to go into great detail on the exercise side because our wonderful lady fairies are going to be demonstrating for us today. But the first image on the left is a really nice example of the holistic approach that I spoke about earlier, how the different parts of the body are interdependent on each other. This is just a broad example, but if you've got a dropped shoulder or a misalignment at the top, you might land up with lower back pain. Lower back pain can lead to knee discomfort, and then of course our feet are the foundation of everything. If that's unstable, again it can move up to knee pain, lower back pain, neck ache. So it's all, like Di mentioned, which came first, the chicken or the egg. You really have to look at the person for what they need, but you also need to look at it from head to toe. People will come in and they're like, why are you looking at my feet? Why are you giving me feet exercises to do? Because it can impact what's going on all the way up the kinetic chain. And then the second image over here is a nice little add-on for scapular dyskinesis. That is basically a term to describe the scapula or the shoulder blades not moving correctly or at the same rate, and they're not sitting or positioned on the spine as adequately as they should be. So just quickly, if you look at the shoulder blade on the left hand side, it's sitting a little bit further or closer to the spine, so it's going inwards, versus the scapula on the right is sitting outward, and it's actually, they're not positioned at the same height, so you'll see that the left is lower than what the right is. So I'm going to go through some examples of movements that we can do to try and educate you on how to strengthen to get that adequate movement and alignment. Certain structures you can't always get 100%, but we try. So the next slide. This is just a generalized strength or examples of strength exercises that we can use. Okay, everybody's different, movements will be different, but this just gives you a bit of an idea of the types of movements that we can do. So on the left, those three images there, the one on the right with the lady pulling her arm outward is for rotator cuff. The gentleman lying on his tummy is also shoulder stability and strength. And then the one with the person lying on their tummy is an exercise that I do with all my clients in order to show them how to set their shoulders and set their posture, maintaining that position while you use the weights and strengthening exercises. So that's a very basic introduction to shoulders. I call it shoulder setting or posture setting. And then the exercise on the right here I've put here because this is quite a complex one and it requires quite a bit of effort to get the range of movement to get into that position, but that will help with the scapulohumeral rhythm and actually strengthening the muscles to be able to support the shoulder, but also using visual feedback with the mirror, you'll be able to see how your arms move and actually get that feedback from the mind to the muscle of how you should be moving and performing the exercises. And eventually, if you cue yourself to move the arms at the same rate while activating properly, it should level out, and you should actually, without looking, eventually be able to do it as equally as possible. The next slide. Pendulums. A nice one that Di mentioned earlier for frozen shoulder, and then I know Mel and Barbara are going to go into great detail about open book and rib cage breathing, thoracic or middle back mobility. And then proprioception, so we spoke about the body's awareness of what the limb is doing in space. This one on the right is a very complicated and progressive one, but I just thought I'd put it in there because it's an unstable surface, so it's really nice to challenge the core. It's really nice to strengthen and allow your body to try and keep as stable as possible while you're on an unstable surface and strengthen at the same time. And then the one on the left is nice for you to just be able to hold the posture, hold the muscle contractions and activations, and be able to move your shoulder in certain directions while everything else is not moving in big movements and compensating. And then the last one is education and lifestyle modification. So these are just two examples that I'm going to give here. Desk setup. So this is what it would look like in a perfect world. It's not always like that for all of us. A lot of the time we make adjustments for what people have got at home. People don't always have money for these ergonomic chairs and these expensive desks. We try and make it as applicable to your life as possible. If your legs can't or your knees are not at a 90-degree angle, stick some books underneath you. Prop your screen up through books or stacks of paper, or I don't even know if phone books are still a thing, but those can also work. And obviously just trying to get your desk height to the adequate level so you can get the perfect, what we would look at as perfect posture, so that you can decrease this from try and prevent this from happening. And this is something I think we're all guilty of, and that's not something that's easy to try and remember, but these are just examples of education and how we try and educate people that this is what you should try and do. I've taught you how to set your posture. Try and implement this while you're sitting at your desk, while you're looking at your phone. And as you think about it more, it actually becomes habit. If you don't think about it and you don't try, you won't implement it into your daily life. So that's another thing, being conscious of it. And that's another part of the process of bio, is making you aware of what you're doing and hopefully carrying it through to what you do in everyday life. Okay, and that is the final one. Okay, so thank you. Thank you. So I'm going to hand over to Mel and Barbara, who are going to take you through some wonderful breathing demonstrations and other exercises.
That's the good news. Yeah. Wingless, because I'm going to poke eyes out. Yeah.
Wait, I need to find you again.
So we're talking about body in blue today.
Not yet. I'm just going to bring that link up.
Thanks, Tammy. Is there a little corner?
I think there's, I'm just looking.
It's a touch.
Not too tall.
Oh, wait.
What's happened?
What's happened? Is that your first slide?
But it should have
A breathing man.
There. Oh.
Your breathing man's gone. Your breathing
For those of you that don't know, none of us are tech savvy. My name's Melanie, and this is my associate Barbara. We have Studio 42 Pilates, and we often say we don't teach Pilates because we've deviated so far from the original 34 moves. But that's within the realm of our influence as far as maintenance and rehabilitation is concerned. After you've been to Tammy, after Dia's ironed you out, we're the maintenance program. And the good news about exercise is that you need to breathe while you're doing it. So as you're sitting over here right now, you're exercising. Yay. And that's where we're about to go. So shoulder mobility is going to be the lid of the cookie jar, but what happens underneath it in this canister is where you're going to want to find a little bit more movement, especially to support what's happening on top. And when you're breathing, you're not just breathing up into the top, you're breathing all the way around. So if, just as you're sitting over there, place a hand on your chest and place a hand on your spare tire number 1. And when you breathe in, you can feel the air go through your chest, and you can fill up into your belly, and you can press. And you can press out at the top here. If you're breathing in through your nose and out through your mouth, you're getting that going. If you're breathing in and out through your nose, It's all here, and that's where it gets up tense into your neck. Okay, and that's what's going to pull you, and that's going to be your shallow breath. So the deeper you breathe, the more you think of yourself as 3D, like an umbrella opening and closing, the more you're going to get that support underneath the scapula, the top of your shoulder, your collarbone. So your breath is important, and it's the most important thing. When you stop breathing, then there's a funeral. Right, what's happening? Can everybody read? So your shallow breathing is caused by anxiety and stress. It leads to using your neck muscles for shallow breaths instead, and that's going to pull on your shoulders. And what we're trying to do is find a way to breathe deeper. Sitting in your car, you can feel that ergodynamic design behind you. You can breathe into your car seat and you can pull yourself out of it again. And in doing so, activate your parasympathetic nervous system. Okay. It reduces your stress hormones, creating more cortisol, promotes healing and tissue repair by increasing the oxygen. The more you use your lungs and consciously think of how they fit, the more you increase your surface area of your lungs. So the bigger your lungs, the sicker you get. No, Mal. No. The more elastic you are, the easier it is to expel and get rid of whatever's attacking you. So to increase the next steps after you've learned how to breathe properly in 3D and all the way around, you're going to have exercises to enhance your breath awareness. And that's just the first one, is placing your hands and feeling how you move. You can put your hands on your rib cage and feel how you move down there as well. And that's going to encourage healthier shoulders all the way around. Range of motion in shoulders is amazing. We're not birds, but we do stand on 2 legs, and we're not fairies, sadly. But that range of motion is something that you don't want to lose and you want to maintain. And they say, with a frozen shoulder, don't stop moving. Move as much as you can. Get the little movements out of it, as sore as it is, even if it means taking handfuls of painkillers. So that was that. What else was to do? Can you remember? Are you going to come like, oh, yes. We're round, not square. Did we miss this? Okay. Are you going to do it? Come right down here, it'll be nice. So yeah, have a little rest. So when you're going to practice starting to move your rib cage, you need little things. It doesn't even have to be a mat. If you look at Barbara's photo, she's put a book between her knees. That's going to keep her hips stacked. Nothing under your head. What if your shoulders sore? You can't lie on it like that. So it's a delicate flower. Okay.
There or there, and just do some breathing, or you can place your hand on your ribs.
So look how she's lying on that thing from underneath. That's your 3D proprioception again. So you can see it up here. She's poked herself up from underneath. She's helping the feeling of it over here on the top. If your shoulders are sore, you can't lie flat on the ground. Put something underneath your head and go and feel how and where your breath goes. So that's the first one. Can you pop us to the next one? When you take the roller in front, this is that movement between your scapula and your spine. But drop back, push forward. So that arm is held in place by the roller, and she's opening up the space between her scapula and her spine. So that's your rhomboid. What's right behind that? Your lungs. So when you're breathing in, you can inflate a balloon from the inside. We're not only made of our outsides. The breathing is what's going to make you up of your inside. And that's what we teach, is all of this. It's a holistic approach. Okay, next. And last. Okay. So chalk circles, they're loose and you need a certain range of motion. So we would usually do this like with what I call the young stack and moyas. The young, strong and beautifuls are going to be able to roll through their shoulders like this, like me. When we get to rehab, you're going to keep your shoulder close and you're going to roll back. So you're rolling through the thoracic spine, supporting it again with your breath against your collarbone. So dropping all the way open and then coming back again while you're trying to keep your shoulder safe, loosening the space between your shoulder blades. It's a very complicated system, but if you're breathing and doing it, there's not a lot of things that you can do wrong. Okay. Side lying is hard on shoulders, I know. So you can do things when you're seated. And one of them that Barbara and I discussed earlier as well is instead of trying to push your shoulders down and back and ending up in an affected posture where you think, oh yeah, so I'm standing up straight now, you're going to actually pick them all the way up. And you can all do it now. You're going to pick your shoulders up, right up around your ears. And this is tense. This is like, oh no, it's a horror movie, okay? And you're going to keep them up there. You can take a breath. And then when you breathe out, you're going to drop them. And that immediately releases your collarbone, your shoulders. You can feel the tension is less because you've over-tensed them and you've said, okay, you want to play up around my ears, you want to play? You don't have to, and you can drop it out. And that is going to relax your shoulders, increase your breathing, and make you feel better all the way around. Right. Barbara doesn't like talking to people. Do you want to say any words? Anyway, thank you for joining us in Studio 42. And we look forward to the next one. Q&A is on. If you want to go and grab a cup of coffee and come back, then we can have a chat and talk about all the rest of it. Thank you.